I'm Dr. Ed Partridge, Director of the Comprehensive Cancer Center at the University of Alabama at Birmingham. And the title of my talk today is 600, Our Failure to Deliver. So I'm sure what you're wondering is what the 600 is all about. So if since 1991, cancer mortality rates have been declining in the United States at a rate of about 1.5 to 2% per year. That's after a steady climb from 1900 to 1991. So we've made progress, and that difference in mortality rates translates to about 400 patients who are not going to die today from cancer because of the advances that we've made and the improvements that we've made in the last 2 decades. The lowest mortality rates in the country are in the most educated individuals. So those with a college education actually have the lowest mortality rates. And if everybody in the United States had exactly the same mortality rates as our best rates, which are in the white college educated individuals, there would be almost 216,000 fewer deaths in the United States on an annual basis. And that translates into about 590 on a daily basis. And I rounded that off to 600. So the 600, that's the topic of my talk today, are the 600 people that will die today from cancer because we have failed to deliver what we've already discovered and already know. And you see on this depiction the number of African American, white, and Hispanic that are in that category of individuals who die really unnecessarily. So if you look back historically at mortality rates or cancer death rates for breast cancer, you'll see that back in 1979, 1981, there was no difference in death rates between African Americans, the pink top line, and whites, the sort of gray line that's just beneath the pink line. There were no differences in mortality rates because we didn't actually discover uh, things that made a difference in outcome until the early 70s. And what we discovered in the early 70s was one, the mammogram, so we could actually detect cancer before it became clinically significant and could impact outcome by surgically removing very early breast cancer. The second thing that occurred in the 70s is we actually developed effective chemotherapy for breast cancer, which also affected outcomes. And patients that got high quality care actually had better outcomes than those that didn't. Those two things, which did make a difference in outcome, as you can see, were delivered differentially. So over time, in the late 70s and then early 80s, we began to see a difference in outcome between African American and white patients. And that difference was because we delivered both mammography and effective treatment for breast cancer differentially. The white population, those that had a higher education or a better income, were more likely to get the mammogram and more likely to get effective therapy when they had breast cancer. Those with lower income, lower education, represented in this slide by African American patients, actually were less likely and therefore had a different outcome. And we see exactly the same thing with colorectal cancer mortality. So you see the top two lines are black males and white males. The top line is black males, the pink second line from the top are white males, and then black females and white females. And again, you see no difference in cancer death rates prior to the early 80s, and then you begin to see the differentiation. Same story as with breast cancer. So In the early 70s, we discovered how we could actually screen for colorectal cancer, first with stool guaiac test, blood test, and then sigmoidoscopy, and finally colonoscopy. And then we also discovered effective ways to actually treat colorectal cancer. And again, they were differentially delivered, and therefore African Americans had a worse outcome than white Americans. So this slide shows breast cancer survival by stage and insurance status. So the red lines, both solid and dotted, are stage 1 breast cancer. The blue lines are stage 2. The green lines are stage 3, and the yellow lines are stage 4. The solid line is an individual with insurance. The dotted line is an individual with either Medicaid or no insurance. And what this shows, and this is data from the National Cancer Database, this shows that there's a difference in ultimate survival in patients who have exactly the same stage disease if they have a difference in insurance status. So those with insurance have a significantly better survival than those without insurance. That's breast cancer. And then the next slide actually shows the same thing with colorectal cancer survival. So again, you can see the difference in ultimate survival in those with insurance who do better than those without insurance, stage for stage. And what's even more disturbing on this particular slide is that if you have stage 2 colorectal cancer and have insurance, you actually do better than someone with an earlier stage, that is stage 1, the red dotted line. You do better if you have insurance with a later stage disease than someone with an earlier stage disease and no insurance. And that's really almost morally and ethically unacceptable for a country like ours. Here you see the impact of tobacco. And you can see that this depicts tobacco rates or smoking trends by degree of education. So the two top lines are no high school degree or a high school degree only, compared to the very bottom yellow line, which is a college degree. And you can see that you're almost 3 times more likely to smoke if you have a lower education, which also translates in most cases to a lower income. And therefore you are much more likely, obviously, as a smoke with a higher smoking rate, to have higher rates of death from tobacco related cancers such as lung cancer, head and neck, and indeed that's what we see. Here's the next troublesome thing on the block, and that's our obesity epidemic. So this is a study published in the early 2000s with data from the American Cancer Society and the SEER registries. And you can see that if you are obese, that is, have a body mass index above 35 or 40, your rate of getting the cancers that are listed here are much greater than someone with a normal body mass index. And if you look down at uterine cancer, that last line on the graph, you can see that if you have a body mass index of 40, which is very much overweight, in fact obese, then you have a 6-fold increase in your risk of developing uterine cancer. And you can see for breast cancer, about halfway down, if your body mass index is over 40, you've got twice the risk of a normal weight woman. And we see the same thing in men. So again, particularly true in liver, pancreatic cancer, but many other cancers, including prostate, there's an increased risk of developing the disease and dying from the disease if you have an abnormal body mass index. And we also know that underserved individuals, that is, again, those with lower education, lower income, are actually more likely to fit in the overweight and obese category. Now, this is what's really disturbing, and this is the increase in obesity rates in the last 40 years in the United States. So you can see on the far right-hand side of the graph that in 1970, only 4% of children aged 6 to 11 were in the obese category. In just 40 years, this has had a five-fold increase. This is particularly disturbing because children that are obese tend very much to also be obese in adulthood. And even among the adults, we've had a threefold increase in obesity rates in the United States. And of course, this leads not only to cancer, which I just showed you, but to other chronic diseases such as heart disease and diabetes. So what have I said so far? I've said that the unnecessary deaths that come from cancer really come from because of four fundamental reasons. One is our continued lack of tobacco control, particularly in undereducated and low-income individuals. Our failure to get age-appropriate screening for breast, cervix, and colorectal cancer. For instance, 42% of women who have Medicare and therefore would have their mammograms paid for in the United States still do not get timely annual mammography. Thirdly, the unhealthy diet and lack of physical activity probably accounts now in the United States today for about 30% of the cancers that occur in our country. And last but not least is our failure to deliver the highest quality of care for cancer to all individuals. Another way to say this is if you think about that individual, that college-educated person who has the lowest cancer mortality in the United States, think about what he or she does. Number one, they don't smoke. Number two, they get the age-appropriate screening. Number three, they have a relatively healthy diet and get some physical activity. And number four, when they have cancer, because they have insurance and disposable income, they get the highest quality care that they can possibly get. So because of what I've already said, the American Cancer Society actually has established a number of mission priorities that deal with the areas that actually are causing unnecessary death in the United States today. So we're going to focus on tobacco control, particularly in those states that have high tobacco use rates. We're going to focus on breast and colorectal cancer screening in those areas that are more likely to have poor, undereducated individuals that would have low screening rates at present. We also want to make sure the American public understands the link between unhealthy eating and lack of physical activity and the development of cancer. And we also want to make sure that every American, when they have cancer, has access to high quality care. So I want to now shift a little bit to what we are actually doing at UAB to actually begin to chip away and eventually eliminate this disparity in outcomes that you see between patients that have education, have a decent income, have insurance versus those that don't. So if you look at a map of the United States and look actually at the distribution of the African American population, you'll see that those counties in which 50% or more of the population are African American, that is the red counties and the orange counties where it's 25 to 50%, Most of those counties are actually in the southeastern United States, and you see very heavy concentrations of African Americans in Alabama and Mississippi. And if you think about sort of historically what's occurred in those southeastern states, if we go back 150 years ago, we know that slavery ended, but there had been basically 200 years of a history of slavery in the United States, particularly the southern United States. And if you go back just 50 years ago, the southern states also had segregation, and integration occurred with the civil rights movement in the 60s and the signing of the Civil Rights Act in 1965. So African Americans have had a almost 200-year history of oppression as slaves brought from mostly from West Africa, and then a 100-year history of segregation. So multiple centuries of institutional oppression, and that history, of course, impacts the relationships today. Going back to our population, we felt, since we were an NCI designated cancer center right in the heart of this crescent, that we should focus on ways to actually eliminate cancer disparities and actually be able to enhance the opportunities for those with low income, low education to have a positive outcome. If you look at cancer mortality rates in the United States, with those red states being those with the highest mortality rates, you can see that particularly the deep south, central, southern states, or the states along the Mississippi River, actually have the highest mortality rates for cancer. And these really are the states with lower education and lower income. So we focused on 2 or 3 areas in Alabama and Mississippi. One, the Black Belt of Alabama, which is about 11 counties in the central portion of Alabama. The Black Belt is actually called the Black Belt because of the deep, dark, rich soil that is present in the area. And it's also because of that soil is obviously the reason many of the cotton plantations were located in this area, and where the slaves obviously came prior to the Civil War. The Delta of Mississippi is northwest Mississippi, and actually prior to the Civil War, it was mostly forest area, but after the Civil War, the forests were cleared, and it became a rich agricultural area with very rich soil again because of the flooding of the Mississippi River into that area and the other rivers. And because of the need for cheap labor, a lot of African Americans actually were migrated into this area for jobs, and it has a heavy African American population also. In fact, if you look at the percent African Americans in both the Black Belt and the Delta, you'll see that it's about 60% African American population with incredibly high poverty levels. So this shows the rural nature of the Black Belt. These are some homes actually in the Delta of Mississippi, and you can see that they are almost third world in nature. So our first attempt to make a difference was the Deep South Network for Cancer Control. It was funded by the National Cancer Institute. And what we did is, using a theoretical framework of working by building coalitions in the community, empowering the community to actually make a difference themselves, and recruiting and training individuals to serve as community health advisors. This was the framework for our program. We recruited originally over 800 volunteers who became community health advisors. We also call them research partners, so that's how the word CHARP, C-H-A-R-P, came about. We engaged over 251 local community partners in these 4 communities, and each one of them had a county coordinator that was paid part-time to manage the volunteers. This is an example of some of the volunteers at work, evaluating grocery stores for food, evaluating the neighborhood for the built environment, seeing whether or not you had walking trails, safe sidewalks, etc. The community health advisors went through an 8-week training program on cancer education with our initial focus on breast and cervical cancer early detection. We also taught them core leadership skills, how to communicate with the individuals in the community. They all had a graduation ceremony, and then they have monthly maintenance meetings where we either give them continuing education or talk about things that they're interested in learning about. So we focused initially on breast and cervix cancer, and then in the second iteration of this project added colorectal cancer screening. But let me show you the results. So this is data from the breast and cervical cancer early detection program, and what's remarkable is on that first line you can see that in the first 30,000 plus women who had their first screen ever for breast cancer, we found 534 cancers, which is a rate of about 1 per 57, which is an astounding rate if you screen a population that's a little more educated and higher income insurance that's been previously screened. The rate is probably 1 in 300 or 400 mammograms. So this is an incredibly high rate, and it shows the impact of a program that actually gets unscreened women into their initial screen. This is something we were particularly proud of, published in Cancer and the American Journal of Medical Science. So before our program, in patients who had Medicare and therefore were covered with insurance, you can see that there was a 16% difference in mammography screening rates between whites, the light colored bar, and African Americans, the dark colored bar. We started our program 1999 and actually began to see a significant rise in the African American screening rates, so that 6 years into our program, there was essentially no difference in screening rates in the Medicare population between whites and African Americans. I do want to point out, though, that these are Medicare patients who are covered, and even with our intense program, still only 58% of whites and blacks are actually getting screening. So we've got to figure out a way to increase the screening rates in those 42% that still aren't getting screened. This slide shows the cervical cancer death rates and our impact on those death rates through the program, the Deep South Network for Cancer Control. So prior to the Deep South Network, we compared patients who came to the University of Alabama at Birmingham and were treated. We compared those from our Deep South Network counties to those from the other counties in Alabama that also came to our institution. And we found that the death rate, or the hazard ratio, was 2.0. This means if you came from a black belt county compared to the rest of Alabama, even getting good treatment at a place like UAB, your mortality rate was twice as high as the non-Deep South Network counties, the non-black belt counties, indicating that you presented with a much more advanced cancer. After we started our program, we compared the patients from the next half decade, and the hazard ratio went to 0.5. This meant you were half as likely to die from the disease if you came from the Deep South Network counties compared to the rest of Alabama. This was statistically significant and indicated that we also were having an impact in this disease also. As we go forward, we are now concentrating on one, reaching those individuals that have previously been unreached, so that 42% of Medicare of the Medicare population that, in spite of the programs that we've used so far, have not availed themselves of the screening opportunity. So we're focusing now on our previously unreached populations, and we are also doing weight loss programs, comparing an individual weight loss program to an individual weight loss program plus community strategies that would enhance the individual's experience. We have a sister project, which also showed a significant outcome. The sister project also uses community health advisors, much like the Deep South Network program did, except as you can see from this slide, what we did is each one of the community health advisors would engage approximately 10 African American women in their community. And in our initial assessment of these 1,531 African American women that were engaged by our health advisors, 14% had never been screened, 16% was screened infrequently, and 70% were adhering to guidelines. But what we found was, after our program started, the proportion never screened went down to 4%, infrequently screened went up to 20%, and adhering to guidelines 76%. But I think what's particularly important is that 71% of the 211 women who had never had a mammogram actually had one after the program started. So we were reaching a population really significantly underscreened. We also took it one step further by actually doing a program in one of the counties in Mississippi where we wanted to increase cervical cancer screening. And it's a small county in the Delta of Mississippi that had, as you can see, extremely high cervical cancer rates. It's one of the purple counties, which are the high rates. And what we did was to do a feasibility study to see if we could actually go door to door and identify women who had not had a pap smear and offer them a free test to rule out cervical cancer, either a pap test or a HPV testing, self-testing that they could do at home. And what was interesting is that we found 119 women who had not been screened in 5 years or never been screened. 64% of them chose the HPV test versus the pap test. But what's more significant is those that actually completed the test were 80% in the self-collection versus only 40% who actually took the time to go to the clinic. This suggests that offering self-collection at home would be an effective strategy for getting really hard to reach women. We took the use of the community health advisor, these lay advisors that are recruited from the community, one step further through a program funded through the Avon Foundation called Community Health Advisors in Action. And what we wanted to do in this study was to see if again, lay advisors or navigators could actually help low-income women who were diagnosed with cancer to actually navigate the health system. So these are some of the things that the patient navigators did. This is some of the barriers that the navigators had to overcome in these low-income women with breast cancer, including transportation, financial issues, navigating the hospital system, etc. But what's significant is that in our entire population, we actually got these low-income, low-educated people to actually make about 93% of their appointments, and therefore were extremely compliant with the recommended treatment. So what I've said so far is that we were able to train lay people from the community to, number one, promote cancer screening, and we were able to demonstrate that it made a difference in breast cancer screening and cervical cancer screening. I also was able to show that we could train patient navigators to help women actually navigate the health system so that they were compliant to their recommended treatment. What I want to talk about next is a program that actually increased African Americans' participation in clinical trials. It's called our IMPACT program. And when we put in our core grant renewal for our cancer center in 2005, we were a little bit embarrassed to realize that if one looks at the second line, the row that's entitled black, you can see that about 20.3% of cancer cases in the United States occur in African Americans, but we were only recruiting 11.2% of African Americans into our clinical trials. And this is really unacceptable. The rate should approach the rate of cancer cases actually that come that are detected in Alabama, and that's 20.3%. So we trained these women, again, lay people, not nurses, not social workers, but just women that we recruited from the community to serve as clinical trial navigators. And in our next 5-year period of time, so the previous data was from 2005, and this is data from 2010, and you can see that our clinical trial accrual of African Americans actually went to 22.7%, which actually exceeds the 20.3% of African American cancer cases in Alabama. So made a significant difference in our ability to get African Americans to participate in clinical trials. To summarize our experience with community health advisors, we've been able to demonstrate that they can promote awareness, change behavior, and increase screening activities, that they clearly can assist with compliance with diagnostic and treatment recommendations for cancer, and that they could increase minority participation in clinical trials. So our next step is to actually broaden the task that we would assign a lay navigator or a community health advisor. So we had the opportunity to apply through the Centers for Medicare and Medicaid Services, their innovation center, for a grant to expand our navigation program. The objectives of the program were to provide better health care at a lower cost. If you look at the cancer continuum, we've utilized, that's that top row, we've utilized community health advisors in the prevention, that's weight loss interventions, early detection, screening, and in active treatment, helping overcome any barriers to compliance with the recommended treatment. So our concept with this new program was to extend the utilization of the lay navigator into treatment follow-up, the survivorship stage and surveillance stage, and even to address issues at the end of life. And we propose to extend that navigator system through the UAB affiliate network, which is 10 sites outside of UAB across the southeastern United States that are shown here. And the idea was that the lay navigators would help us provide high quality care, overcome system and community barriers, reduce overall health care costs, and I'll talk about that in just a minute, and improve overall health. And the way we would do that would be to reduce unnecessary emergency room visits and therefore hospital admissions and ICU days, keep patients on clinical pathways, reduce the use of non-curative chemotherapy in the last 2 weeks of life, have earlier adoption of hospice care, and provide the highest quality of life for people diagnosed with cancer. It's anticipated that with a $15 million investment, we'll be able to save almost $50 million in Medicare through this program. So this is the administrative support with our 11 community-based navigation teams. Now, what have we learned? Well, we know that the task of eliminating disparities probably is not as daunting as it might seem at first glance. So the technical advances to be delivered are not very complex. Tobacco control, age-appropriate screening, healthy diet, physical activity are not particularly expensive. The only thing that really costs in those three is screening, and of course it's covered by insurance when insurance is delivered, when the whole population has access to insurance. The populations at risk are geographically focused. Certainly the new Patient Protection and Affordable Care Act will potentially eliminate barriers to access by making insurance affordable for all or most of our citizens. And we've learned, obviously, that the communities at risk are most eager to engage. That is, even in the Black Belt of Alabama, the Delta of Mississippi, the community has been engaged. I believe that the easier to more difficult challenges are actually here. So screening, which is a one-time annual or maybe every 5-year or 10-year event, would seem to be the easiest behavior to modify. Tobacco control, we know how to do that with high taxes and clean indoor air. High quality treatment for all should be addressed by the Affordable Care Act. The one that seems perhaps the most difficult as we look at it today is to get people to actually eat healthy and become physically active and reduce the obesity epidemic that we have today. So let me summarize that one can work with communities that have typically been suspicious of organizations and institutional activity. And you can do that by creating trust, eliminating bias, and sharing power with the community. So thank you very much for attending this session. I look forward to seeing you soon.